Okay, thank you for this opportunity. Good to go. Yeah, I thank the organizers for this opportunity. I've been, it's a tough act to follow, Dr. Gauri, and then on a topic like this, it's going to be very difficult. I'll try my best. So first, lowdown on what we know about what are the current roles and indications of neoadjuvant systemic. I've changed from neoadjuvant chemo to neoadjuvant systemic in DTC. There is no established role of NACT. We do not even know what are the definitions and indications for locally advanced thyroid cancers. There is no high quality trials published. There are not even any large trials which are registered or going to accrue in the near future. Even ETA 2025 is sitting on the wall, and it is kind of friend zoning neoadjuvant systemic by saying, let's await larger trials. So I think I should begin and end my presentation with this slide, right? But I have to present a nuanced presentation. I have about 13-14 minutes, so I'll try and do my best. Here we go. We know that 15% of DTCs are locally advanced, and they portend worse prognosis. A lot of them are going to be aggressive variants of poorly differentiated thyroid cancers, but there are several gray zones there. Firstly, there is no uniform or comprehensive definition. Until very recently, there has been paucity of dedicated guidelines for these cancers. Until now, surgery has been the mainstay. It is associated with morbidity, and when you resect vital structures, there is often distressing and lifelong complications. There is no established role of neoadjuvant systemic therapy to downstage or to downsize the tumors. So what has changed in the past few years? Firstly, we have attempts at better definition of locally advanced thyroid cancer. That's come from several consensus. The AHNS recently collaborated with ITOG. Dr. Ashish isn't here today, but he might elaborate on this tomorrow. We at ISTS also tried to define this. The major theme defining locally advanced thyroid cancer is gross invasion of one of the major structures, trachea, larynx, esophagus, recurrent nerve, more bilateral, and major vessels. Bulky nodal disease, which is causing extranodal extension into these structures or causing vascular encasement, and some definitions also use biological criteria. These are also exciting times for research because there is better understanding of genetic alterations based upon the cancer genome atlas. There is understanding and application of immunotherapy to a whole lot of cancers. There is identification of actionable alterations or mutations within thyroid, and there is research into newer molecules which will target these mutations and also which will act at a downstream pathway. And all of these has led to the evolution of neoadjuvant systemic therapy in DTCs. I have removed the word chemotherapy because there is no role of conventional chemotherapy in differentiated thyroid cancer. So I'm not going to speak upon that. The game changer, of course, was the SELECT trial, and lenvatinib had extraordinary action in radioiodine refractory recurrent thyroid cancers. So its impressive activity was, kind of used in the neoadjuvant setting as well. And the rationale was that it may improve oncological clearance, especially in R2 cases where you leave behind gross residual disease, to make it to R1 or even R0, to decrease the morbidity of resection and therefore improve the quality of life, and to improve the locoregional survival rate as well as the overall survival rate. The principle always was to identify alterations and then use targeted molecules which would be acting upon them. So that was the entire principle of neoadjuvant systemic therapy in thyroid cancers. So what were the mutations commonly used? So of course the targeted agents, which is my second line, targeting RET, NTRK, BRAF, MEK, all of these, but much more commonly non-targeting or a blanket kind of multi-kinase inhibitors, which Professor D. Cruz spoke in the morning. They were much more commonly used, such as lenvatinib, sorafenib, the Chinese ones, apatinib and nilotinib. More and more immunotherapy have been combined with tyrosine kinase inhibitors and multi-kinase inhibitors, and a lot of these trials are under investigation. And what is the evidence right now? Hierarchy, let's understand the hierarchy. There is no RCT. Whatever evidence we have is of low quality and heterogeneous, mostly dominated by case series, case reports, and only 2 small published phase 2 studies. We recently have a meta-analysis of 119 patients, only came out last month. And we have few multi-institutional real-world data, the largest of them coming from the Harvard group and one from Latin America. So let's look at them one by one. This is the hot of the press meta-analysis. This is 23 studies of all kinds, 119 patients. The most common agent used was lenvatinib, followed by apatinib and sorafenib. It included some non-DTCs as well here. Overall, the tumor volume reduction in the pooled set was 25 to 87%, and the RECIST criteria partial response rate was 33 to 77%. You see a lot of heterogeneity there, anywhere between 1/4 to 90%. But the good thing was that the progressive disease was uncommon, only in 7 patients, and even better was that conversion to surgery, most of them were unresectable to begin with, or resection with severe morbidity to begin with. Conversion to surgery occurred in 83% of the cases, and R0 or R1 resection occurred in close to 90% of these patients. Now let's move to the published phase 2 trials. I said that 2 were included in the meta-analysis. I actually found 3. All of these emanate from China, and all of them use Chinese molecules. So on the top 2, anlotinib, apatinib, they are Chinese multikinase inhibitors. Surufatinib is a slightly novel, but again a multikinase inhibitor. And toripalimab is a anti-PD-1 humanized antibody. So all of these are Chinese trials, small numbers you can see, 26 being the largest. If you look at response rate, once again in the range of 2/3, toxicity is manageable and pretty consistent with what you would see with tyrosine kinase inhibitors. But many of these drugs are Chinese. They are available in India through the Bangladesh route, but not majorly applicable to our scenario. And therefore, we move on to the real world evidence, and this is where the meat of the evidence is. I've chosen this study, though the Latin American study was slightly bigger, not only because we have more correspondence with the PI, which was Dr. Randolph, but also because the primary endpoints in the study were rooted in surgical relevance or surgical common sense. So this was a real world study, 2 centers across Boston and Sydney. Now they are involving 2 more centers in MSKCC and MD Anderson, but this concentrates only on 2 centers, 17 patients of locally advanced thyroid cancer who were either unresectable or resectable with high morbidity. All underwent NGS to identify molecular alterations, and then NGS specific neoadjuvant therapy was given. When it was not, when an alterable mutation was not found, then lenvatinib was given. Various histologies and therefore various targeted agents were used. And these are the novel endpoints which I said. So they devised 2 endpoints, both of them very well rooted in surgical understanding. Both of them talking about the complexity of the surgery. So these are basically complexity indices. One is the MMM surgical morbidity complexity score. Second is the invasive thyroid class. I'll just brief about them in the next slide. Secondly, outcomes for percentage of patients who became resectable and percentage of R0 or R1 patients versus R2 resections. So that's one of the surgical complexity index. Basically, they have allotted 1 point each to organs at risk according to increasing severity. The more precious or more organs at risk will garner more points, and this is calculated at baseline, post neoadjuvant completion, and at surgery. Similarly, there is the invasive thyroid class. This nothing but categorizes the surgery which would be into mild, moderate, severe, very severe, and finally unresectable. Once again, calculated at baseline, completion of neoadjuvant treatment, and at surgery. So these were the outcomes. Both MMM and invasive thyroid class showed significant decrease. The median tumor reduction was to the extent of 37%. Surgery could be performed in 2/3, and R0, R1 once again in 2/3 of these patients. Adverse effects were what would be expected with these agents, but more importantly, there were 2 cases of tracheal fistula where large tracheal disease was present before, and as a disease when a tracheal fistula occurred, and these patients could not then be resected. Overall 12-month PFS was around 58%. This has led to a number of ongoing trials, and I've generated this slide from an LLM model. So these are all the trials which I could find there. And these cover a number of agents. They have lenvatinib, they have specific targeted molecules such as verimifinib or sinibolimab, and they have immunotherapy in the form of pembro. They also have selpercatinib for RET positive PTCs. However, there are several limitations of current evidence, and we spoke about them before. Nonetheless, being that they're extremely heterogeneous with a whole set of different endpoints. But most importantly, patient eligibility is not uniform, and that is something we need to work upon. So there's a very important need for uniform patient selection. So the patients have to be either resectable or borderline resectable tumors with anticipated R2 risk or high morbidity resections are anticipated, or imminent airway or vascular compromise. Going ahead, only these patients should be selected for receiving neoadjuvant therapy. Once again, MDT consensus is essential, and where possible, enrollment into trials is encouraged. That's the proposed algorithm for any neoadjuvant systemic and locally advanced thyroid cancers. Confirm unresectability, perform NGS-based molecular profiling. MDT then chooses which agent to use. Start neoadjuvant therapy, give it for 8 to 10 weeks. Hold the drug for 2 to 4 weeks. Perform surgery and then adjuvant according to histopathology. The HNS ITOG has recently given the schema of how to do this, and they advise that tissue-based NSG should be, NGS should be done first. If that is not possible, then you individually test for mutations. But what happens if all of these mutations are negative? So the Randolph group has addressed that, and if all of the mutations are negative, you can then start with lenvatinib. So that brings us to the question, can lenvatinib be used as a designated standalone molecule as a neoadjuvant? Given that most DTCs do not have targetable mutations, and given that lenvatinib action is tumor mutation agnostic, it probably can be used even in the absence of molecular testing. And one phase 2 trial is currently underway, headed by Professor Randolph. That brings us quickly in a minute about our data of upfront lenvatinib in advanced thyroid cancers. I do not have the time to present all the results, but 8 patients, same once again, the criteria used for advanced resectable or advanced or anticipated R2 or resectable but highly morbid. Intent was neoadjuvant in 5 patients and as per response in 3 patients. Just a pictorial representation to show that the responses were good. Responses were seen in 6 out of the 8 patients. All 6 have undergone surgery. 2 had stable disease. R1 in 2, R0 in 4. Toxicities were common, though we found slightly more incidence of hand and foot syndrome. We used biosimilar, which is the Indian biosimilar, and the cost was around 18,000 rupees per month. So, to conclude, surgery is the mainstay of management of locally advanced thyroid cancers. Neoadjuvant therapy is a promising option, but need for guarded optimism and very regulated patient selection. In those DTCs who do not have a specific mutation, lenvatinib can be a good standalone agent to begin with. Good response, which is seen in about 2/3 of the patients finishing. It improves resectability and decreases morbidity. Results from ongoing phase 2 trials may either pave way for a paradigm change or may disprove this rationale, but we need to await them. And finally, this is not an escape route for doing lesser resection. If you have a tumor which is resectable and does not fit into any of these criteria, go where the disease takes you to achieve an R0 resection. Thank you so very much.